So good afternoon all. You have your first lecture of psychiatry. Psychiatry is a sister branch of medicine, and this is not different from any other branch of medicine. It has same protocol to assess the disorder, to diagnose, to treat, and to follow with the patients. And it has lots of other aspects like medico-legal and issues related to ethics, and we have major psychiatric establishment in India. We are going through the history of psychiatry and what is there in psychiatry by and large. So to start with, uh, what is psychiatry and who are psychiatrists? Psychiatry is a branch of medicine focused on diagnosis, treatment, and prevention of mental, emotional, and behavioral disorder. It deals with mental disorders, emotional disorders, and behavioral disorders. So, a psychiatrist is a doctor who specializes in mental health, including substance use disorder and psychosexual disorders too. A psychiatrist is qualified to assess both mental and physical aspect of psychological problem. Some problem may represent as physical disorder. It may have underlying psychological causes. You may understand in your further lectures. There is a difference between psychiatrist and psychologist. Psychologists usually are PhD in clinical psychology or MPhil in clinical psychology, and it's a different branch from psychiatry. And both practitioners are practicing in the same field, but there is minor difference. Like they are usually go with the psychotherapies and treatment which is which is not psychopharmacological. They cannot prescribe the drug. They can imply the psychotherapies, counseling, and psychoanalysis, such a thing. And central to their practice are psychological assessment, clinical formulation, and therapies related to psychological aspect. So here are the few contributions of psychiatrists in the past. You are well known, must be aware about the Sigmund Freud. He gave the topographical theory, Oedipus complex. He is known as father of psychoanalysis, and it's a therapeutic technique. His books were the interpretation of dreams, beyond the pleasure principle, civilization and its discontents, and the ego and the id. So these are the Sigmund Freud's contribution. Aaron Beck, uh, she was an American psychiatrist, contributed to cognitive therapy. He wrote the book Cognitive Therapy of Depression, The Evolution of Psychotherapy. Similarly, the major psychiatrists in the past were Carl Jung, Alfred Adler, Eugen Bleuler, Nathan S. Klein, Harry Stack Sullivan, and Emil Kraepelin. Carl Jung was a Swiss psychiatrist, found the analytical psychology and the structure and dynamics of psyche, the psychology of religion, and psychological types. Similarly, Alfred Adler is best known for his theory of individual psychology. He remained concentrated upon one individual for psychopathology. Eugen Bleuler worked on schizophrenia. Klein worked in field of psychopharmacology, basically biological psychiatry. Sullivan is best known for his work on interpersonal relationships. Emil Kraepelin developed first system of psychiatric nosology. He classified the psychiatric disorders. In clinical psychologists, the major contributions were of William Wundt, the father of experimental psychology; William James, the principal of psychology; Ivan Petrik Pavlov, he gave classical conditioning theory. Similarly, B.F. Skinner gave the operant conditioning. Jean Piaget gave the child development and cognitive psychology. Erikson gave the theory of psychosocial stages of human development. Albert Bandura gave the social learning theory. Anna Freud given the worked upon the beating fantasies and dreams. She published this book, and the ego and the mechanisms of defense. So this is the brief of history of psychiatry. This chapter won't go in the depth of these uh, individual slides. You will get to know more about these aspects in your further lectures, which will be in detail. So the burden of psychiatric disorder, you can see the depression and anxiety disorders are most common disorder globally, and in which anxiety disorder tops against the depression too. So anxiety disorder, the prevalence is 3.8% and depression is 3.4% as per the data of 2017. In Indian scenario, again, the depressive disorder and anxiety disorders are the most common one and are equally prevalent in Indian population. And this is data is taken from the Lancet Psychiatry 2020. In etiological model, what are the causes of psychiatric disorder? There are many theories like medical or biomedical models, psychoanalytic theory, attachment theory, evolutionary psychology, and different authors give their own different theories. And when assimilated in today's era, we can say that the best model for psychiatric disorder is biopsychosocial model, in which there is element of biology, element of psychological aspect or psyche of the person, uh, and social context, socio-cultural environment is equally responsible for development of a psychiatric disorder. So in biopsychosocial model, the biological aspect is physiological aspect or pathological aspect of the disorder. In psychology, the thoughts, emotion and behavior of the patient, how they cope up with the distress, how they cope up with the stress, what are the defense mechanisms, and uh, the thought process of the individual plays role in development of psychiatric disorder. Similarly, social environment like socio-economical conditions, socio-environmental condition, and cultural factors such as work issue, family circumstances. These are the maybe contributory factor to the psychiatric problem. This biopsychosocial model was first conceptualized by George Engel in 1977. So one factor is not responsible for development of psychiatric disorder. This is the uh, combination of all these three. In biological factors, prenatal damage may cause uh, psychiatric presentation in the adulthood or in later childhood. Infection at the time of pregnancy, disease or toxins at the time of pregnancy may lead to uh, psychiatric problems such as compromised intellectual abilities, injury and brain defects at the time of parturition. In biological factors, neurotransmitters are also implicated in development of these disorders. For example, abnormal levels of dopamine activity corresponds with the several disorders like ADHD, obsessive compulsive disorder, and the level of dopamine are increased in schizophrenia while reduced in attention deficit hyperactivity disorder and OCD. The another neurotransmitter is serotonin, which is implicated commonly in anxiety disorders and depression. And chronic substance abuse too may lead to uh, further psychiatric problem like alcoholics hallucinosis or alcohol-induced dementia or anxiety disorders. Other than biological factors, life experience and environmental factors may also play a role in development of psychiatric problem like poor parenting in childhood, abuse in the childhood period or neglect. Adverse childhood experience like abuse, poverty, malnutrition, and traumatic experiences. Familial and close relationship problems like parental divorce, death, absence of parents, or lack of continuity of the family. Social expectations and esteem, both too low or too high self-esteem can be detrimental to an individual's mental health. So this is the part of psychological part. Communities and culture like poverty, unemployment, underemployment, lack of social cohesion, and migration from one place to another place may also lead to uh, psychiatric problems. So this is the question, what is psychosis and what is neurosis? Basically, psychiatric disorders are classified previously as psychotic disorders and neurotic disorders. The psychosis is condition when the mind that results in difficulties determining what is real and what is not real. This means uh, there is a lack of understanding what is going on. So lack of touch with reality is psychosis, and symptoms of psychosis may include delusions, hallucinations, extreme psychomotor agitation, extreme psychomotor retardation, and catatonia. And neurosis is the term mainly used uh, today by the followers of Freudian thinking, who described neurosis as a part of anxiety, and often that has been repressed. Repression is a uh, defense mechanism which will you understand later in your lectures. So what is the difference between psychosis and neurosis? In psychosis, insight is absent. In neurosis, it is present. In psychosis, judgment and reasoning is impaired, while it is intact in the neurosis. Reality contact is lost in psychosis. Reality contact is present in neurosis. Delusions are usually present in psychosis while absent in neurosis. Hallucinations are also present in psychosis, and true hallucinations are usually absent. Pseudo hallucinations may be present in neurosis, which is not the part of psychosis. Change in the personality may be there and usually absent in neurosis. So few disorders which comes under neurosis are depression, borderline personality disorder, panic disorder, post-traumatic stress disorder. And in psychosis, we found schizophrenia, uh, paranoid disorders, persistent delusional disorders, and paranoid personality disorders. In paranoid personality disorders, there are brief episodes of psychosis, but which is not sustained and remain for the longer time. So how to assess a psychiatric patient? The assessment is a process of gathering information about a person within the psychiatric service with the purpose of making a diagnosis. You have to evaluate the person, gather the information from the patient itself, from the family members or other source of information to make a diagnosis and to manage the patient. It includes social and biographical information, your direct observation of the person, and data from specific psychological test. If you found difficulty in making diagnosis, you can go for a diagnostic psychological test to assist in the or making in the right diagnosis. This assessment can be multidisciplinary. Nurses, psychologists, occupational therapists, social worker, and professional counselor may also include to reach a conclusion or to make a diagnosis. So in the assessment part, we all know that we have to collect the demographic profile. Like in medicine, in psychiatry, we also used to collect the demographic profile, including the personal information of that patient, like name, age, sex, the residential area, source of referral. Uh, Then the chief complaints, and pertaining to those chief complaints, we also note the onset of the complaint, the course of the illness, the total duration of the illness, episode of the illness. Which episode is this? Some illnesses are episodic, like bipolar affective disorder. You will find many episodes in the past. The number of episodes the person had in the past. The precipitating factor, which leads to the development of exacerbation of the illness. Predisposing factors like family history, you have to note. Perpetuating factor means the factor which is uh, keep on the psychopathology not resolving, or the psychopathology is going on despite of your best effort. The perpetuating factors are sustaining those psychopathology and not caused to resolve by the treatment. Past previous treatment history. The mnemonic is OCD and EPT. O is for onset, C for course, D for duration, episode, then P factors, and the last is treatment. Then comes the history. Similarly, the history of present illness, past illness, uh, medical illness specifically in case of psychiatric patient, personal history, including birth complications, childhood development, parental care in childhood, educational history and employment history, relationship and marital history, and any history of litigation if the patient is have currently or in the past. Further, the history also includes an inquiry about the individual's current social circumstances and family relationships, current and past use of substance or illicit drugs, and the individual's past treatment history, current and past diagnosis. Cultural values can influence the way a person and their family communicate psychological distress and response to a diagnosis of mental illness. So the cultural factor also contributory for the making a diagnosis, eliciting a psychopathology, and in also the treatment. Some person have notion that the abnormal things are normal and prevail in society, and they consider the abnormal thing as a normal part of their community. Now comes the assessment of mental state, which is also called as mental state examination. This is the examination of mental state of the person, and it has basically 10 domains in which the first one is general appearance and behavior, how the person looks like and how the person is behaving, and including the other factors, whether the person is conscious or not, whether clouding of conscious is there, person is oriented to time place person or not. Sometimes what happen, patient present with the psychiatric symptoms, but actually he is having physical problem in secondary to which the person is behaving abnormally, like infections of CNS or electrolyte imbalance may lead to delirium like condition which has psychosis like features. So first of all, you have to rule out the organicity by virtue of this consciousness and orientation. Then attention and concentration of the person, affect, thinking, perceptual disorders, memory impairment, intelligence of the patient, judgment and insight. So we will look for these 10 factors one by one. In general appearance, you have to look for if there is any abnormality of gait, which is indicative of any organic factor. The gait may be abnormal, like as ataxia, stamping gait, circumduction, waddling, lurching, foot drop, etc. You have to look for this. The build of the patient, whether he is mesomorphic build, whether he has ectomorphic or endomorphic build. Personal hygiene, whether it is poor, average, or good. Grooming of the person, whether the person is overly groomed, under groomed, or adequately groomed. And in psychomotor activity, whether it is decreased, increased, average, uh, extreme excitement is there, or the person is hostile or not. So you have to look for these things, and these things are indicative of certain kind of psychiatric disorders. Abnormal movements like tics, tremors, athetosis, chorioid movements, or other type of movements like chorioathetoid movements, hemibellismus, you have to check for this. Eye to eye contact or gaze of the person, whether it is poor eye to eye contact, the eye to eye contact is uh, made, but it is maintained or not, it is sustained or not, and rapport with the person is established or not. So therapeutic alliance between the therapist and the patient is made or not. This is very important, particularly in the field of psychiatry. It also indicates that rapport is poor in case of psychotic patients when the repo is not made adequately, while it is somewhat good in neurotic disorders. Then you have to assess for consciousness and orientation. The definition of consciousness is a state of awareness. So you all know that you have to check for consciousness in case of patient of neurological disorder or other disorders. So you have to find whether the patient is fully conscious or he she has alter consciousness or stupor or coma. And along with this consciousness, you have to check for disorientation to time, place, and person, which is indicative of delirium. The patient is disoriented, he is in the state of delirium, and both of these denotes the organicity. Organicity means the reason for this presentation is physical, not psychological or psychiatric presentation. Attention is checked by digit span test, and it is amount of effort exerted in focusing on certain portion of experience. And concentration is ability to sustain a focus on one activity, or the sustained attention is concentration. So attention means when you entered in the class, you gave attention while I was speaking. You gave attention to my instructions, and then you are continuously listening to me. This means you are having good concentration and you are concentrating on the lecture, while some of the students are not. They are looking at their phone and doing some other work. Their concentration is poor. Uh, they have impaired concentration basically. Now comes the affect and mood. There is difference between affect and mood. Affect is immediate expression of emotions, the emotion which you are immediately expressing. It may be differ from the different period of time, and affect is a psychopathologic finding, and it may be subjective. What the patient is thinking about, what how the person is perceiving his state of emotion right now, and objectivity means how the therapist, examiner, or interviewer is perceiving the effect of the patient by observation. Intensity of effect, whether it is decreased, increased, or average. It is increased in some disorder and decreased in uh, some other disorder. For example, in mania, the patient may remain irritable most of the time, or cheerful, or have elevated mood most of the time, while the depressed patient have depressed mood or sad mood. The range may be shifted towards depressed, elevated, anxious, or angry mood. And in case of psychosis or schizophrenia, the effect is uh, constricted, and or if it is severely constricted, uh, it is known as flat effect. Appropriateness of the affect, while the person is talking about some issues, his expression of emotions while matching with his thoughts or not. For example, he is discussing about some sad moments which happened recently, and but he is cheerful, and his immediate expression of emotion is shifted towards cheerfulness. This is inappropriateness. And similarly, relatedness means if you can relate your feeling with the expression of the patient. The mood is different from affect. Mood is a pervasive and sustained emotion, subjectively experienced and reported and observed by the others. It is a sustained, it is not for a time being, it is not for immediate expression, which is sustained for longer period of time, uh, which the person himself or herself acknowledge, and it is also acknowledged by the others. This is the part of personality, whether the person is jovial, cheerful, or he may be uh, having depressed intonation or almost all of the time. So this is a part of personality. So these are the few emojis which depicts. First one is for cheerfulness, and in the top right, what is your perception? What kind of emotion is this on the top right? Shock, anxious affect. You can say the person is in anxiety. The third one is depressed, and the fourth one is flat. So you have to observe for speech also the loudness of speech, rhythm in the speech, prosody, intonation of the speech, pitch, phonation, articulation, quantity of speech, rate of the speech, spontaneity, and latency of the speech. In thinking, there are three parts, which is divided into thought process, thought content, and thought possession. So in thought process, we used to look for flow and form. In flow, whether it is decreased, average, or increased, whether there is a push of speech, pressure of speech, whether the speech is interruptible or uninterruptible, whether there is a thought block or poverty of speech. In the form, we used to look for grammatical corrections and meaningfulness, what the patient is saying, whether it is irrelevant, incoherent, is there any loosening of thought, any derailment. It is also known as Knight's move. What is Knight's move? Can anyone tell? Flight of ideas, word salad, neologism. What is Knight's move? This came from the game of chess. Knight is what we used to call the ghoda in the chess. He used to take two step ahead and then he derail from his track. So this is derailment. While the person is talking about something, and he derail from the original topic. This means Knight's move. Similarly, flight of ideas usually found in manic patients, word salad, and neologism. Neologism is creation of new word. In thought content, poverty of thought may be there. The content may be minimal. Overvalued ideas. An overvalued idea is an emotionally charged belief which is usually prevail in the society. Delusion is a false belief which cannot be corrected by reasoning and not in the context of sociocultural background and intelligence of the patient. So this is the definition of delusion. Preoccupations are thoughts which have an undue prominence in the person's mind. It is not delusion, it is not overvalued ideas. The person is preoccupied with one aspect of his or her life. Obsession is found in obsessive compulsive disorder. It is an undesired, unpleasant, intrusive thought that cannot be suppressed to the patient's volition. Repetition of thoughts, and in lieu of those thoughts, in reaction of those thoughts, the person used to do act, which is known as compulsion, and obsession is thought process. Phobia or anxiety is a dread of an object, situation that does not really pose any threat. Yeah. Thought possession, you may find thought insertion, withdrawal, or broadcasting. The thought insertion is the person reveals like some of thoughts or whole of thoughts may be taken by another person or another force or another figure. Withdrawal means withdrawal is the thoughts are taken away from the mind, and insertion is the plotting of thought. Someone has plotted the thoughts in my mind. This is thought insertion. Thought broadcasting means the person will depict like his thoughts are broadcasted by means of media, whether it is TV or newspaper or social media. These are the disorder of thought possession. In perception, one can have illusions, hallucinations, pseudo hallucinations, derealization, and depersonalization. Perception means how do we perceive? We used to perceive by virtue of five sense organs. You know, uh, like hearing, tasting, and olfaction, visualizing, and the sense of touch and pain. So there are five sense organ. So in hallucination, uh, one can have abnormality one out of these five senses. Hallucination, and most common hallucination in psychiatric disorders are uh, auditory hallucinations. Then comes the memory, impairment in memory. Memory is test in the domain of immediate memory, recent past memory, and remote memory. The judgment refers to a patient's capacity to make sound, reasoned, and responsible decisions. It may be personal judgment, social judgment, or test judgment. In intelligence, we used to look for general fund of knowledge, simple arithmetic calculations like simple addition, subtraction, multiplication, and division. In abstract thinking, multidimensional thinking with ability to use metaphors and hypothesis appropriately. In the last, we used to look for insight. Insight is the person's understanding of his or her mental illness. Insight may be present in the patient or may not be present, or it may be partially present. There are six levels of insight. The first one is complete denial of illness. The person complete denial. I am not having any kind of problem. I don't have any symptom. I do not have any illness. In the second, there is slight awareness of being sick and needing help, but denying it at the same time. He realizes, but uh, at the same time, he denies he is having any illness. In the third, the person blames it on to the others or external factors or on the organic factors. In the fourth one, the awareness that illness is caused by something unknown in the patient. Then comes the intellectual insight and true emotional insight. In intellectual insight, the person knows about his sign and symptoms, he knows about his illness, he acknowledges the abnormality, uh, what the psychopathology he or she is having, they acknowledge that as abnormal thing. But in true emotional insight, along with the awareness, they also know how to deal with the problem and how to uh, go with the relapse prevention. By relapse prevention, by changing their behavior or keep with the compliance with the treatment, and whatever the instructions are given, they are usually comply with those instructions. After clinical evaluation, there are some scales and psychological testing which are useful in assessing the psychiatric disorder. Here are the few examples of scales. The first one is Hamilton rating scale for depression. The second one is Montgomery Asberg depression rating scale. For manic patient, Young Mania rating scale. For schizophrenia, positive and negative syndrome scale. In dementia, mini mental status examination. HAM A for anxiety and Y box for obsessive compulsive disorder. There is ADHD rating scale for assessing the attention deficit and hyperactivity disorder, and alcohol use disorder identification test. In short, it is audit for alcohol use disorder. In the right side, you will find the psychological test, which are helpful in uh, making the decision. The first one is Rorschach test, then thematic apperception test, draw a person test, sentence completion test, picture arrangement test, Seguin form board test, Bhatia battery test, Malin's intelligence test for children. So after assessment, here are the classification of mental disorder. You have assessed and found certain psychopathology in the person, and now you have to categorize those psychopathology in a disorder. So various classification are available, like ICD-10 or DSM. The latest edition of International Classification of Diseases, 10th version, which is given by World Health Organization, and we also used to follow this guideline of WHO. And in American Psychiatric Association, DSM-5 is used, which is known as Diagnostic and Statistical Manual of Mental Disorder. The current edition is DSM-5 Text Revision, DSM-5 TR. In ICD-10, the chapter F is for the ICD-10 is for all of the medical disorders, and out of these chapters, chapter F is for psychiatric disorder and further classified on and coded accordingly. For example, F00 is for organic mental disorder, F10 for substance abuse disorder, 20 is for schizophrenia and related disorders, F30 is mood disorders like bipolar affective disorder, depression and recurrent depression, 40 is for neurotic and stress related and somatoform disorder, the 50 is behavioral syndrome associated with physiological disturbance and physical factors. F60 is disorder of personality and behavior in the adult person, 70 for mental retardation, 80 for disorder of psychological development in children and adolescents. The 90 is for behavioral and emotional disorder with onset usually occurring in childhood and adolescence, like ADHD, autism, Rett disorder, or other pervasive developmental disorder, or other neurotic psychiatric disorder like conduct disorder and oppositional defiant disorder. The last one is a group of unspecified mental disorder. Now comes the physical examination. After diagnosing the person with the psychiatric disorder, one is must to go for routine blood test like CBC, LFT, blood sugar, urinalysis, kidney function test, and according to the comorbid physical illness, one can go for testing for diabetes mellitus, tuberculosis, and associated condition. For example, in substance abuse disorder like alcohol use disorder, one should look for abnormality in liver function test and can go for LFT and ultrasound USG upper abdomen. And in case of smoking, one can look for COPDs. Rule out the imitating illness. For example, thyroid dysfunction may also present as psychiatric illness. Anemia may also present as depression because of one of the feature of depression is easy fatigability, which is also found in severely anemic patients. SSPE may also present as psychiatric illness, which mimics like obsessive compulsive disorder. Rule out any organic illness if you suspect by imaging like CT scan and MRI. Drug monitoring should be done uh, in follow-ups for certain drugs. It is mandatory, like in clozapine, you have to go for uh, TLC and DLC weekly for first 6 months, and one should look for serum lithium level also if you are giving the patient lithium carbonate, and you have to keep vigil on the drug side effects also, and accordingly lab test may be done to look for that. Then the treatment comes. In the treatment, various classification of drugs are available according to the disorders like antipsychotics for psychotic illness, also known as neuroleptics, antidepressants for depressive disorders, mood stabilizer for mood disorders like mania and bipolar, anti-anxiety for anxiety disorders, and psychostimulants for illness like ADHD. In non-pharmacological management, psychoanalysis, psychotherapy, behavior therapy, cognitive therapies are uh, available or can be used. Sometimes brain stimulations are also helpful, like electroconvulsive therapy. You may also have uh, heard about this, ECTs, cranial electrical stimulations, CES, transcranial magnetic stimulation, TMS. These modalities are also beneficial in certain disorders in which these are indicated. Psychosurgeries may also one of the resort for psychiatric disorder. For example, implanted cortical stimulator known as ICS, deep brain stimulation and vagus nerve stimulation, cingulotomy and leucotomy. In certain disorder, hormonal therapy is also implicated, like hormone suppression, estradiol administration and androgen administration. Now comes the forensic psychiatry. Psychiatry is also having forensic aspect, like in other branches also. So it has psychiatric disorder may have legal issues, or it may be involved with medical legal issues with the person. So if we go in the past, in 1843, the case of R versus McNaughton opens the door for defense of insanity in such a person. In the year of 1964, the renowned foreign psychiatrist D. Lawrence Friedman introduced the term forensic psychiatry as a subspecialty of psychiatry. So, in context to our in our setup, here are the few points one should keep in the mind and look for. Like Section 84 provides unsoundness of mind as a defense, and it was inserted in the Indian Penal Code. Section 328 to 339 of Code of Criminal Procedure 1973 gives provision as to accused person of unsound mind. Person with disability, including mental disability, we have the Act PDA 1995, National Trust Act to encourage people with autism and cerebral palsy or mental retardation to live as independently and close to the society. Hindu Marriage Act we also know, and it also has implication with the psychiatric problems. And recently we have Mental Health Care Act, introduced in 2017 after Mental Health Act. So here is the point which is being discussed for section 309 IPC, and which is related to attempt to commit suicide. Previously it was it was a punishable offense, and but now it is limited by virtue of mental health care bill, and attempt to commit suicide is decriminalized after the long discussion in parliament. So as we have ethics in other branches of medicine, we have ethics in psychiatry also. And the first committee was held in the Cuttack in 1989 and comprises of Professor J.S. Nikki, Professor D.N. Nandi, Professor A.K. Agarwal, Dr. V.N. Vahia, and Dr. J.K. Trivedi. And they formulated the code of ethics for practice in psychiatry. So the main goal of ethics in psychiatry is uh, to upgrading, so to prevent the to deal on the serious note, to maintain highest possible ethical and professional standards, such as upgrading, ganging, touting, self advertisement of your practice, uh, unavailability of your uh, expertise, publishing research and report to the press, the unethical drug trials. It deals with the teaching with unprepared topics, not upgrading self through CMEs, selling of sample medicine, prescribing unscientific drug formulations, practicing quackery, dichotomy of fee splitting, offering or receiving kickbacks. So these are the few things which deals with the ethics in psychiatry. So we have major psychiatric establishments like NIMHANS Bangalore, Central Institute of Psychiatry, Kanke Ranchi, Institute of Mental Health and Hospital Agra, Institute of Human Behavior and Allied Sciences, Delhi. So these are the few of the major establishment in psychiatric services. So here are the few words regarding Indian Psychiatric Society, founded in on 7th January 1947. The organization holds its origin in 1929 as the Indian Association of Mental Hygiene, and after independence in 1947, it started with the 15 founding members, and now has grown to membership of above 7,000 psychiatrists. So this is regarding the National Mental Health Program, which was started in 1982. It has three components: treatment of mentally ill, rehabilitation, prevention and promotion of positive mental health, and it has their aims and strategy to imply the psychiatric health services all over the country. So we have done with the introduction of psychiatry and somewhat the history of psychiatry. Now we want to go through some questions which may be helpful to your understanding and further readings, or if you are preparing for some uh, competitive examination to pursue in the field of psychiatry or psychology. So the first question is, mental state examination include the following except? Yes, diagnosis. So topographical theory was given by Sigmund Freud. Yes. Classical conditioning theory was given by yes, and this theory involved ringing of bell and experiment with the dog to produce the food with the bell, and the dog conditioned to the ringing of bell for getting the food. Most common psychiatric disorder prevalent in India is depression and anxiety both. The model theory which describes the best etiological model in psychiatry is following are the features of psychosis except no, not catatonia, no, not not excitement. So anxiety is a neurotic feature. It's a neurotic trait. It's not psychotic trait. In psychosis, there are five features. One is delusion, second is hallucination, then extreme excitement, extreme retardation, and catatonia, which is not the part of mental state examination. Anyone else? Yes, it is pre-morbid personality. Intelligence is the part of MSc, as we had discussed. There is a general fund of knowledge, simple arithmetic calculation, and abstract as a sub-part of intelligence. Hallucination is a, yes, it is perceptual disorder. EMS is used for, it is, it is used for diagnosis, prognosis, treatment, as a lab test, or electroshock therapy. It is used for treatment. One of the modality of treatment in the psychiatry is, one is drug, another is psychotherapies, and the third one is the brain stimulation, under which this comes, transcranial magnetic stimulation, then psychosurgeries and hormonal therapies. All are the treatment modalities in psychiatry except, yes, right, electrocautery. So thank you.